Yes, good evening, friends. Today we have Dr. Senthil Rajappa with us in this episode of IGMPO Talks. The topic is management of hormone-sensitive prostate cancer. One of the important topic. A lot of medical oncology students struggle in the management of hormone-sensitive prostate cancer. We are usually good in CRPC, but hsbc requires a close understanding of the Gleason score. A lot of people struggle with that. Cooperation with the radiation oncologists and the urologists, and Senthil will, I think, sail us through all these aspects of management of HSPC. Over to you, Senthil.
Thanks, Padmaj, and thanks all of you for joining again this evening. As Padmaj rightly pointed out, this is a topic that almost all of us think we know everything about. But when you have a patient sitting in front of you, then you realize how much you actually don't know. And that not knowing is actually an ongoing process. As you ask more questions, you have lesser answers and you go searching for them. And that's what we'll try to do in the next 40 minutes. So this is how prostate cancer patients progress through the various states and stages. Now, you could have presentation in two broad categories. One is you start with localized prostate cancer, and then after treatment for your localized prostate cancer, you may end up relapsing. You have a castrate-sensitive state and then a castrate-resistant state. And metastatic prostate cancer, in spite of the many advances that we have made today, remains an incurable disease. The other set of patients are patients who present de novo with metastatic disease. Now, why is this discretion important? As we go by, I will show you that some of these patients who relapse after having treatment for localized disease have a slightly different natural history compared to patients who present with de novo metastatic disease. So today we are going to discuss about this category, right? So this category is castrate sensitive, hormone sensitive prostate cancer, okay? Because you got an M0 CRPC now. So this is castrate resistant prostate cancer. So you may have a state wherein there is no clear evidence of metastasis, but that patient is actually castrate resistant. Now, this is not the topic for today's discussion. However, if there are some questions, I'll be happy to answer that at the end of this talk. For today's talk, we will focus on castration sensitive or hormone sensitive M1 disease. Again, let's start with this case, which will illustrate the many points that I want to elaborate on today. So here is a 67-year-old male with lower urinary tract symptoms, history of diabetes, history of coronary artery disease, both well controlled. The brother had a prostate cancer at 60 years and aunt had a breast cancer at 45 years. Now that should immediately ring a bell. The reason is that today in CRPC, so castrate-resistant prostate cancer, again, we won't deal with that today. The BRCA status has an important bearing on many decisions that are made. So when you see a patient like this and you've got a history like this, so that should ring a bell, get your BRCA done. This patient is an ex-smoker. ECOG performance status is 1. There's a hard nodule on digital rectal evaluation or examination. Here are the investigations. PSA is 110 nanograms per mil, a Gleason grade of 4+4. Now, today you will have a group, right? So instead of grade 4+4 or 3+4, 4+3, whatever that might be, you now have a group, the highest being 5, right? So if you have somebody with 5+5, that's actually 5. Sometimes 5+4 is also Gleason grouped as 5. The higher the number, the lesser the differentiation, worse the prognosis, right? So this is important to keep in mind. So all patients today with hormone sensitive metastatic prostate cancer end up having a PSMA PET CT that's easily available in our country. But in many parts of the world, they don't have the luxury of doing a PSMA PET CT. So in that case, they end up doing a CT scan of the abdomen or an MRI of the abdomen, plus minus the chest, and a bone scan. Typically, even now in the EUA guideline, you will not see PSMA PET CT as the investigation of choice. It still continues to be the conventional imaging, but slowly everybody is moving to a PSMA PET CT. So these are important things that you need to have a diagnosis: PSA, your Gleason grade on the biopsy or the Gleason group, the PSMA PET CT if your patient can get that, right? So these are very important baseline information that you want in your patient with metastatic prostate cancer. Now, our patient had a 2D echo. The ejection fraction is 40%. So 67-year-old, diabetic, coronary artery disease, family history of prostate and breast cancer, ejection fraction is 40%. All of these are very, very important points to consider when you're making decisions for this patient. Now, this is the PSMA PET CT. You see a lesion in the vertebra, and then you see a lesion in the left hip. So these are the areas. So there are two bone lesions. Again, remember where these lesions are: the pelvis and in the vertebra. Again, where the lesion is also very, very important. I'll show you very soon why that is important. What do you offer him? Should it be ADT only? Should it be ADT plus secondary hormonals or the newer anti-androgen agents? Should it be chemotherapy? Should it be ADT plus radiation to the primary site? And you've got only two other sites. So why don't we radiotherapy that also? Or should you do ADT plus radiation to the primary site plus secondary hormonals or chemotherapy? So you've got 5 choices that you can use in your patient with hormone sensitive prostate cancer. Now, one question that's important to ask is orchiectomy better than an LHRH analog or an LHRH antagonist, or Degrelix as it's known today? Now, let's make that simple. There are 2 situations where we would prefer an LHRH antagonist or an orchiectomy. Situation number 1, where you want a rapid drop in the testosterone levels because your patient is highly symptomatic. Okay, where you want an immediate rapid drop in your testosterone levels because your patient is highly symptomatic. That is one place where you would certainly want to do either orchiectomy or an LHRH antagonist. What's the second situation that you may want to choose one of these two over an LHRH agonist? The second situation is where your patient has got uncontrolled diabetes, uncontrolled lipids, uncontrolled cardiac disease, and so on and so forth, because the incidence of major cardiovascular events is higher when you use an LHRH agonist, which means you're using triptyline, you're using leupride, or one of those. These are drugs that increase the incidence of major cardiovascular events, right? So in a patient who has one of these risk factors or has pre-existing cardiac disease, especially if it's uncontrolled, then you would want that patient to go either on an LHRH antagonist or a orchiectomy, right? What's the ultimate difference in terms of outcome between these 3? So far, we don't have any demonstrable evidence that one of these 3 is better compared to the other. Okay, so the clinical situation is what should determine whether you use orchiectomy or an LHRH antagonist. These 2 are equivalent. Or should you be using an LHRH agonist? Okay, so that confusion should not come in your next patient with hormone sensitive prostate cancer. Again, the repeat of the same slide that I showed you earlier. Why am I showing you this? Because now you've got so many options that you can use along with ADT in your patient with hsbc. Why are we doing this now? Because now we have clear evidence to show that ADT only is a suboptimal option in terms of overall survival in general for your patients with hormone sensitive prostate cancer. So you have either chemotherapy to add on, or you have one of the newer anti-androgen agents that you can add on to your ADT. Remember, ADT remains the sheet anchor of treatment. You could add one of these other agents along with ADT because now it's clearly shown to improve overall survival. Let's start at the very beginning. Risk stratification in hsbc, right? Now, you could classify depending on which trial or agent that you're talking about. On the left is typically what's been used in the chartered study. Now, the chartered study looked at ADT versus ADT plus docetaxel in hormone-sensitive prostate cancer. Addition of docetaxel led to improvement in overall survival. Now, there you had patients who were divided into high and low volume. What is high volume? High volume means your patient has got visceral metastasis, number one, or your patient has greater than or equal to 4 bone metastasis, at least one beyond the pelvis and vertebral column. Remember, I showed you the case with 2 bone metastasis, one in the pelvis and one in the vertebral column. So if you have only 2, that patient becomes low volume. If you have at least one lesion beyond the pelvis and vertebral column, it could be skull, it could be the ribs, it could be the humerus, it could be the femur. Even one lesion outside will be called as high volume disease. Okay, so this is the problem. If you have 4 or more with at least one, you're calling it high volume. But if you have 10 in the vertebral column and pelvis, you need not necessarily call that the same way. Okay, so where the bone metastasis is very, very important, right? That's an important point to carry home today. If you're looking at studies like Latitude, you're looking at poor risk patients. Now, what is poor risk? If your patient has 2 or more of these 3 factors that I have listed here, Gleason 8 or more, greater than or equal to 3 bone metastasis, the site does not matter, or if you have visceral metastasis, right? So these are situations where you're calling this patient as poor risk. If you have more than 2 of these factors, you will call it poor risk. If it's 1, it is not poor risk. Okay, so remember, high and low volume, poor risk versus not. Now, the question that we will very soon answer is, does this classification really stand its ground in the way we practice hsbc today? We'll come to that very, very soon. Now, this is the updated result from the chartered study. For the overall population, there was an improvement in the overall survival, 13 months in the first follow-up at 28 months median. The second follow-up was at 53 months, nearly 5 years. You get a 10-month improvement in overall survival. Now, this is for all patients who entered into the study. Now, when you did a subset analysis, only patients who had high volume disease, remember what's high volume? Visceral or greater than or equal to 4 bone metastasis with at least 1 beyond the pelvis and vertebra. So if you had a patient in this group, then that patient ended up having an overall survival benefit with the strategy. While if you had low burden or low volume disease, you did not have any benefit with the addition of docetaxel. So this is only high volume disease. Remember, for the whole group, the intent to treat, the overall survival benefit was 10 months, while here you get an overall survival benefit of 17 months. Recollect, where else in medical oncology do you get an overall survival of 17 months? Hardly any. The only other place I can think of is HER2 positive metastatic breast cancer, chemotherapy plus dual anti-HER2 therapy, around 15 months of overall survival benefit there. So it's rare that you get such a huge overall survival benefit with some very healthy hazard ratios, 0.6. So chartered docetaxel plus ADT results in overall survival benefit 17 months, hazard ratio of 0.6 in patients who have high volume or high burden disease. What about the role of chemotherapy in patients with low burden or low volume? Now, that's where one of the confusing areas is. Now, this is from the Stampede trial. Stampede also looked at the very similar question. Docetaxel in addition to ADT, does it result in overall survival? Now, Stampede is a little more heterogeneous in terms of patient selection. It had some patients with high risk localized disease, some patients who had relapsed. Now, if you look at the Stampede study, half of all patients that went into the Stampede study had metastatic disease. Now, when you look at the subset analysis of patients with low burden disease in the Stampede M1 group, M1 is metastatic group, you clearly see that there is nearly a 15% absolute improvement in overall survival. Remember, in the Chartered, we said there is no benefit for low burden patients. But in the Stampede, they could clearly show that there is an absolute improvement in the overall survival of nearly 15%. Again, a rarity in medical oncology itself. That is higher than the absolute benefit that you get in patients with high burden, 10% in high burden, while you get nearly 15% in low burden. So the first and a very important lesson that we have to learn today is that chemotherapy is also an option for patients with low burden, metastatic, hormone sensitive prostate cancer, because we have always been taught all the time that chemo is only for patients with high burden disease. Now that has to be unlearned, and this has to be relearned today. Now remember, we started by saying that patients who relapse after localized prostate cancer and get metastasis later have a slightly different biology compared to if you have somebody who presents with de novo metastatic disease. Now, let's divide these patients into 4 groups, okay? This is M1 patients. Let's divide them into 4 groups. Now, if you have somebody with de novo, low volume, de novo, high volume, somebody who's relapsed after local therapy for prostate cancer, relapsing as low volume, relapsing as high volume. Now look at where the outlier is. The outlier here is patients who've had previous therapy for localized disease and then relapsed with low volume disease. Low volume means less than 4 or equal bone metastasis, no visceral metastasis, and nothing in the the appendicular skeleton as defined by Chartered. Now, if you have a patient like that, that is a patient which has got excellent overall survival with just ADT. While look at all the other groups, even though you might have a patient with low volume disease, this patient still has an outcome that is not so great. So a low volume disease that relapses after, or rather that has relapsed after treatment for localized prostate cancer, has a different outcome. It's got an inherently better biology compared to if you had prior treatment and came back with high volume, de novo, irrespective of what the volume is. Now, why is it that you have to understand this point? 2 important reasons. Reason number 1 is that clearly explains why Chartered did not show a benefit in patients with low volume disease. Now, this is Stampede. You've got de novo patients, you've got relapsed patients. We said relapsed low volume has very good prognosis. Now, you hardly had any patients with relapsed and low volume. When you come to Chartered, look at what actually happens. You got prior local therapy and patients who relapsed after prior local therapy. This was nearly half of all patients, and majority of them are low volume patients. So you had a group of patients in Chartered who had relapsed after localized therapy for prostate cancer. These are patients who have inherently good prognosis and are unlikely to benefit from the addition of docetaxel. And since this formed a significant proportion of patients with low volume, Chartered did not show a benefit for addition of docetaxel in this group of patients. Now, on the contrary, if you had patients with low volume, but majority of them were de novo, then you would have certainly found an outcome very similar to what you got on the Stampede. So now we have a reasonably convincing explanation as to why the charted was negative for patients with low volume disease. So let me reiterate this point. Low volume or high volume, it doesn't matter. Your patient is a candidate for chemo plus ADT. The only group where you may have a doubt or may not want to use docetaxel is a patient who's got low volume disease, but this low volume is a patient who's relapsed after treatment for localized prostate cancer. Okay, very, very important phenomenon to keep in mind. Now, let's move to the new kids on the block. Which are these? These are the newer anti-androgen agents. You've got two important agents, rather three important. One of them is old, which is abiraterone. You've got enzalutamide and apalutamide, which are again newer anti-androgen agents that have now had approvals in this setting. What did they do? These trials were very similar to the charter, right? They took patients with hormone-sensitive prostate cancer, randomized them to ADT only or a combination of ADT plus enzalutamide in these two studies and apalutamide in the Titan study. The primary endpoint was overall survival in the ENZAMET study, co-primary relapse radiographic progression-free survival and overall survival in Titan, radiographic progression-free survival in ARCHES. All right. All these studies were positive studies, but remember that there were some differences which are very, very clinically relevant again. Now, remember, in all the other studies, you had ADT plus placebo randomized to ADT plus a newer anti-androgen agent or docetaxel. In the ENZAMET, we had our great friend bicalutamide as the ADT plus the anti-androgen in the comparator. So you had randomization, ADT plus enzalutamide in the test arm, and the comparator was ADT plus bicalutamide. So it was not placebo here. Remember this very important point. The other very important point was in the ENZAMET, about 40% of all patients had both docetaxel and enzalutamide for their hormone-sensitive prostate cancer. So it's wearing a suspender and a belt at the same time. So about 40% had both of these therapies, right? So this is again a clinically very relevant factor, and I will tell you very soon why. Now, these are the hazard ratios for abiraterone, apalutamide, and enzalutamide, all for overall survival. Point number one, irrespective of whether it's low risk, high risk, low volume, high volume, you had an improvement in the overall survival for the addition of the newer anti-androgen to androgen deprivation therapy. Look at the hazard ratios all through this forest plot. You will find that it is positive. Let me repeat, irrespective of whether you had low risk, high risk, low volume, high volume, newer anti-androgen agents actually ended up benefiting in terms of overall survival when added to ADT. So that's very clear. But where does this little confusion come? It comes when you're using enzalutamide. Look at what happens in high volume patients. Enzalutamide ends up crossing the center line, or the upper limit of the confidence interval crosses 1. Remember, when it crosses 1, it means that it's not significant. So does it mean that enzalutamide is not useful in patients with high volume disease? The answer is no. Why is it no? Because in this group, majority of patients had also received docetaxel. So the lesson that you learn from this forest plot is that if you have a patient who has hormone sensitive prostate cancer, is taking ADT and is receiving chemotherapy, there is no role for the addition of enzalutamide. If your patient is receiving enzalutamide, there is no role for adding chemotherapy over on top of that. So both together is not better than either of them alone when added to ADT. Now, how is that very clear? Now, if you tease out those patients with docetaxel, okay, remove those patients who had docetaxel, and if you take patients who had enzalutamide only along with ADT, look at where those hazard ratios end up 0.38 and 0.65, which is quite healthy, which is very similar to what you got with docetaxel in the high burden disease. Okay, so carry home from this. Irrespective of low or high volume, low risk or high risk, newer anti-androgens add to overall survival. Point number two, when you're using an additional therapy to androgen deprivation therapy in hsbc, it should be either chemotherapy or a newer anti-androgen agents. When you put both of them together, there is no additional benefit over compared to either of them alone. So these are very important points that you have to take home. Great. Medical oncologists love numbers and hazard ratios. So now we are saying enzalutamide, apalutamide, abiraterone can be used irrespective of the risk and volume. We said docetaxel also can be used irrespective of the risk and volume. So how do you do? What do you choose in your patient? Is there a way to choose? Unfortunately, there are no randomized trials which are trying to answer this question. So unfortunately, we have to cross compare hazard ratios between studies. Don't go through this very detail. All the red ones are the chemotherapy ones. All the blue ones are the newer anti-androgen ones. The only observation that I want you to make here is that the hazard ratios seem to be better for the newer anti-androgen agents compared to chemotherapy. You see 0.6 is the number. This is for the intent to treat population, because we are now saying everybody can have, in addition to ADT, another agent. So we are not dissecting this to low burden, low volume, high volume, and all of those. In the intent to treat population, these are the numbers, and the numbers certainly looks better for the newer anti-androgen agents compared to docetaxel. So over the board, the risk of death is reduced by 25% with docetaxel compared to 35% with AR targeted agents. Okay. So I'm slowly starting to believe, and I have already changed my practice. These days, I rarely use docetaxel for patients with hsbc and who need an additional therapy over and top of their anti-androgen or ADTs, androgen deprivation therapy. Now, that may be a small bias that I have, but that's the way my practice has changed post-ESMO. Is this what I am doing? Am I romancing the newer anti-androgen agents? All of us probably are to a certain extent, but please be very careful with these things. The choices are galore because you've got abiraterone, you've got enzalutamide, tomorrow you may have apalutamide. The vital statistics, I'm talking about the hazard ratio, not what you're seeing here on the screen, might look better, but you have to be aware that it can be look easy, but it ultimately might be very, very fatiguing because you have to run a long race. Can be cardiotoxic, especially abiraterone. It can cause haywire electrolyte imbalances, not typically a drug that you would want to use in your uncontrolled diabetics. False fractures are quite common in patients with enzalutamide and apalutamide. Enzalutamide, there's a slightly higher incidence of seizures. Abiraterone can play havoc with your liver, though in a very small group of patients. Again, something that is very, very neglected, a lot of unknown and unnoticed drug interactions. You have to be very careful with all of these when you're using a newer anti-androgen agents. Compliance is a problem. It's like hormonal therapy in breast cancer. So you need to be very careful and monitor them in the long term so that you don't end up in a situation like this. So when you're romancing, learn how to romance them well. Now, this is a cross comparison from the STAMPEDE study, a very interesting cross comparison, because STAMPEDE by itself is a very interesting study where the comparator keeps changing as you go by, the standard of care keeps changing. So at the same time, there were patients who were being enrolled on docetaxel on a different study in the STAMPEDE arm. At the same time, the abiraterone was being used in another arm. So when they cross compared, it looked like there is absolutely no difference in terms of prostate cancer cause-specific survival. There are so many network meta-analysis which have done, which will tell you that one agent is better over the other and so on and so forth. But the simple answer to is one better over the other is we don't know. So I think you need to choose based on all of these characters. Tablets are easy to administer, safety profile, at least in the short run, looks better. Long-term steroid use, if you're taking abiraterone, 33 months on an average. Drug interactions are important. important. Compliance is a problem. Costs, insurance are a problem. Then the question is, what do I do for CRPC? Will my patient tolerate docetaxel later? Should I be using docetaxel early is always a question. Docetaxel might be cheaper, shorter in terms of administration, but has adverse events that are more in the short run. Now, is docetaxel better for visceral metastasis? There's no data to actually support that. Is docetaxel better in patients who have a high PSA? There's no clean data to support that. Is docetaxel better if you have a higher Gleason score? The answer is no. There is no evidence clearly to say that in any subgroup for that matter, docetaxel has a better outcome compared to abiraterone and enza, because all of us are again taught that if you've got visceral disease, docetaxel is better. Show me the evidence for that. There is absolutely no evidence for that in patients with hormone sensitive prostate cancer. So to summarize that part, we've got a small part coming up, but to summarize that part, docetaxel, high volume, high burden, high risk, yes. Low volume, low burden, low risk, again, yes. But in a very small group of patients who have relapsed after local disease with low volume, those patients may not have a significant benefit with docetaxel. Otherwise, docetaxel, abiraterone, enzalutamide, apalutamide, all of these are choices irrespective of the risk and burden. Okay, so we quickly move into radiotherapy next 5 minutes and then we wind up. Remember, in the choices that we asked, we also discussed questions regarding bone metastasis and what is the benefit of local therapy to the prostate in patients with hormone-sensitive prostate cancer. Now, why is this question come up? Because we now know that there is seeding of metastasis from the primary, there is seeding into the prostate again from these metastatic cancer cells, which are all the time circulating. And so it makes some sense to actually block the cycle and radiate or do surgery to the prostate in patients with metastatic prostate cancer. There's a lot of retrospective evidence to support this strategy. So which patients should actually be having locoregional therapy in hsbc? We will try to answer that question. Again, the stampede arm, H, of this trial clearly showed that if you had somebody with low burden disease and you radiated the prostate in these patients, this is standard of care plus radiotherapy compared to standard of care in low burden disease, there is an improvement in the overall survival. 0.68 is the hazard ratio. If you had somebody with high burden disease, then radiation to the prostate was not useful. So low burden radiation to the prostate is useful. Now, stampede arm H was a docetaxel arm. It was not the abiraterone arm at all, right? Now, is the radiotherapy, when I mean is the radiotherapy, does the type of radiotherapy matter? No, whether it's the weekly schedule, that means hypofractionation, or if you do daily radiotherapy with the conventional fractionation, it doesn't matter. The type of radiotherapy does not matter in terms of the benefit. The other very important question that one needs to answer is, remember that M1A means non-regional nodal lymph nodes, which make it M1, right? Let's say you have a retroperitoneal, a para-aortic lymph node. That is M1 disease. Now, you've got M1A, M1B, M1C. M1C is visceral, M1B is bone, B for bone, A is non-regional lymph nodal metastasis. Now, what happens if you radiate non-regional lymph nodal metastasis patients? I mean, radiation to the primary. These patients have a benefit because these patients have better outcome even compared to bone metastasis. So when they looked at the stampede H arm, patients with non-regional nodal metastasis that classified them as M1 ended up having a benefit with radiotherapy to the primary, while if you had visceral metastasis, those patients did not have any benefit out of adding radiotherapy to the primary. So low burden disease, lymph node only metastasis, making them M1 benefits from radiotherapy. Interesting question. How many bone metastasis group of patients are likely to benefit from radiotherapy? Look at the kind of dissection that they have done to the data. Interesting. You may call it torture of data, but I think it's quite relevant to torture data sometimes. Now, if you have 1, 2, or 3, then you're likely to benefit from radiotherapy. While if you had 4 or more, now remember that's the cutoff that you have between low burden and high burden. So when you get to 4 or more bone metastasis, radiotherapy to the prostate does not help. So low burden, nodal metastasis, low burden as defined by less than 4 metastasis, benefits from radiotherapy. So that's the summary of the indication for radiotherapy in patients with hsbc, low burden disease, 4 or it's less than 4 metastasis. These patients are likely to benefit from radiotherapy. Do we have randomization between surgery and radiotherapy for the loco-regional therapy? The answer is we don't have a randomized trial. We don't have a randomized trial showing that surgery is beneficial. So far, whatever randomized evidence that we have or the subset analysis from these studies that we have, it looks to be that there is evidence for radiotherapy to the primary. Do we have evidence for radiotherapy to the oligometastatic sites? The answer is no. So as of now, we will not go about radiating those 2 bone metastases that we had in our patient. We started by saying prostate, 2 bone metastases. This is low volume disease, so we will radiate the prostate. We will not use abiraterone in our patient because our patient has diabetes, our patient has heart disease, ejection fraction is 40. So we will not use abiraterone in our patient. We will probably not use docetaxel because I think it'll be a little harsh on this patient with so many comorbidities. So for me, in our patient, I would say ADT, enzalutamide with radiotherapy to the primary would be the best choice therapy for the patient that we started with. We will end now. This is the sequence, right? This is the sequence that we are seeing today for patients with metastatic prostate cancer. I don't really have the time to go through this in detail. In 2020, this is what we are doing: Abi, Enza, or apalutamide plus your ADT. Then you go on to use olaparib. Our patient, if tested positive for BRCA1 or 2, will be a candidate for olaparib. Then you go to docetaxel, cabazitaxel. You can bring back your your newer anti-androgen here. Rucaparib is a drug that has got approval in this particular setting. And then you have PRRT, RAD233, phosphoterol, dexamethasone, all of these things that we have in our armamentarium today. So sequencing has to be personalized, and personalized. There is no one standard sequence that you can have for all your patients. It's going to depend so much upon your attitude, affordability, and the patient's access to all of these therapies, because if you don't have this, then all this academics does not mean anything. So let's summarize. Having said that all agents can be used for all groups, today the division of risk grouping, either in terms of a poor risk, good risk, or in terms of a low volume or high volume, is actually only prognostic. You don't have to choose your therapies based on which groups these belong to, and hence these risk groups are actually losing their relevance in today's practice. Docetaxel and the newer anti-androgens prolong overall survival when added to ADT in hsbc. The NAAs, or the newer anti-androgens, seem to be having an edge, but there is no objective criteria to help choose between these agents. When it comes to the newer anti-androgen agents, it's the comorbidities and the adverse event profile which should help you to decide, because again, there is no one that's better than the other in that group. I'm telling abiraterone, enzalutamide, and apalutamide. Please be aware of the adverse events and drug interactions. RT to the prostate in selective cases. Which are the selective cases? Bone only, low burden disease, and nodal metastasis can have radiotherapy to the prostate, in addition to all the therapies that we have discussed. So I will stop there and hand it over back to Padmaj. I am seeing 16 questions already. So Padmaj, you got a long way to go today. Thanks so much for that patient hearing.
I see. Yes. Start with the question. I think you can see in your screen.
Yes.
I think the first is from AV. I don't know who this AV is, anonymous. I don't know why people have this funny idea of, I mean, WhatsApp also you find a lot of odd names. You don't know who the person is.
And sometimes numbers.
Yeah, numbers, and then the Q Sera or something like that. No, so he's putting in a comment that we prefer an antagonist when there is a borderline obstruction, cord compression, urinary tract obstruction. When can you get away without ADT?
So I don't really know a situation where you can get away without ADT. ADT forms the sheet anchor of treatment for hormone-sensitive prostate cancer or prostate cancer metastatic in general. So there's no question about getting away from ADT. I think you have something to ask, but you've not asked the right question. So you still have time to type it again. Padmaj will sure take it again.
Senthil, it is me. When you,
Sir, how are you?
Ajit,
Ajit,
oh, you were there.
coming with AB.
Yeah, go ahead.
Sure.
Can you please ask your question? I'm not able to understand that.
Yeah, so actually there are two separate questions. One is the comment actually that when there's a
I think-
borderline pending obstruction,
Yes.
like a borderline spinal cord obstruction
Yes,
or
I
a
agree. I agree.
obstruction, it's better to avoid agonists which may cause a flare and completely.
Absolutely agreed. So
And
either
the second-
orchiectomy or the antagonist there.
Yes, exactly.
Yes.
And secondly, when patients want to retain their libido, sometimes you can get away without ADT by a combination of what, if I remember rightly, finasteride or dutasteride with, I think it's a probably, I don't know, remember the second agent. There's a combination of drugs that you can give, and the patient can have similar castration effects without actual castration.
I think, is it cyproterone acetate?
Yeah.
I don't know, but I'm not sure that that's the standard of care, Dr. Ajit. So maybe
No, it's not. But
in
the phase
a
2 trial,
very,
I know
very
bicalutamide with
Yes.
finasteride.
okay.
If the patient
I'm not aware
is
of
not
that.
consistent on maintaining his libido.
Okay.
But
I'm not
fantastic
aware of that. Anyway,
I learned lots of new things with you. Thank you so much.
thank you so much, sir. Thank you so much. So second is Zoom
Yeah,
bombing.
so it turned
Third
out
is
to be
Cleopatra.
a veteran. Okay. Ajit, okay. Ajit, a good friend. So the next, yeah, Ajit, again, Ajit comments. Any subgroup where only ADT
I think Ajit's comment there is also correct. I believe it's not this or that, it is this and that. Absolutely correct. Absolutely correct.
Yes. Any subgroup where only ADT is considered and any role of intermittent ADT in current era?
Very good. Only ADT is a frail old person with very minimal metastasis, let's say a few lymph nodes as the sites of metastasis or a couple of bone metastasis only, who is not a candidate for either docetaxel or any one of these newer anti-androgens because of an adverse event that he may not be able to bear with. So that's one. Number two, that's also a situation wherein the life expectancy of the patient is very short, let's say a year, a couple of years, because of many other comorbidities. You don't want to add too many therapies and make a mess of his whatever life that is remaining. So these are two situations where only ADT can be considered. Intermittent ADT again is, I would say, again in two situations. One is if a patient is not tolerating ADT because of whatever reasons. It could be, it could be hot flushes, it could be problem with his libido, it could be one of the cardiac events and so on and so forth. That's one situation. The other situation is where you started with very, very low volume disease. If you can have a category like that, one lymph node, two lymph nodes in the retroperitoneum, very small volume disease, wherein again the benefit of the addition of all these agents may be not very huge. So that's another situation where we would want to do intermittent ADT, but one has to clearly know and understand that the non-inferiority of intermittent ADT to continuous ADT has clearly not been proven. So it's not a standard of care, but can be used in very selective situations.
With regards to the comment by Ajit, the last comment that it is not docetaxel or NAA, I think you mentioned that in the first slides of yours, that docetaxel, the problem of tablets not being covered in insurance, I think it's a big problem. Most of the patients that's not a scientific data to say, but a lot of people end up taking docetaxel just because of that reason, that is being covered in different yojana government if they are poor, or if it's insurance. So I think that's an important thing. We can't just say docetaxel or NA. I mean, just a comment.
Rakesh has asked, should we also stratify patients based on symptom severity, choose between, you're talking about newer anti-androgens, not ADT, newer anti-androgens and chemotherapy? No, Rakesh, I would think that the initial symptom control actually comes with the ADT. It is not because of the chemotherapy or the newer anti-androgen agents. So if you have lots of symptoms, as Dr. Ajit clearly mentioned in his comment, you should either get an orchiectomy done or LHRH antagonist there. That's what is likely to bring your symptoms down fast. The choice between chemotherapy and newer anti-androgen agent will not depend upon the burden of disease. In fact, there's nothing to say that one is better over the other depending upon the burden of disease. As I said, some people think if it's visceral, you need to use docetaxel, but I'm yet to come across clear evidence to say that that's the case. Nidhi Agarwal, you should ask Padmaj, Dr. Nidhi, as to whether you can get the recording of this lecture.
Yes,
Ravi
I will be
Jaiswal.
soon uploading. Yep.
Great. Ravi Jaiswal has asked, how do you choose between AbbVie and Enza other than side effect profile in clinical practice? Side effect profile is the only one, Ravi, because now you've got enzalutamide that is as cheap as abiraterone or as expensive as abiraterone, whichever you want to call it as. So I think beyond that, I am not clearly aware of a criteria that you can use in order to choose between the two. Nidhi Agarwal, how neoadjuvant hormonal therapy should be given? Dr. Nidhi, neoadjuvant hormonal therapy is a term that you would use in the context of localized prostate cancer and not in the context of metastatic prostate cancer. Neoadjuvant hormonal therapy continues to be experimental in loco-regional or localized prostate cancer. It is not the standard of care. There are some phase 2 studies which show that there is superb response in the prostate if you use neoadjuvant hormonal therapy. It's like breast cancer. We are trying to push therapies earlier, trying to push the world based on this term called pathological complete response and buy everything away. I think at this point in time, it remains experimental. So there is no role for neoadjuvant hormonal therapy. Neoadjuvant is a term that you use if you're planning some loco-regional therapy in a patient with localized disease. We are talking about metastatic disease here. So the term does not apply. Thank you for the excellent lecture, Ravi. Thank you so much for that compliment. Dr. Nidhi, again, leuprolide and bicalutamide both should be given. Okay. In today's practice of prostate cancer, I think bicalutamide seems to be having a diminishing role. So if you're using leuprolide, then you use it along with either chemotherapy or one of the newer anti-androgen agents. Bicalutamide clearly has not shown to be better than sequencing ADT followed by bicalutamide. It only adds to the adverse event profile. So in today's practice, I wouldn't really be able to tell you which patient should have leuprolide and bicalutamide. Unless you say you want to combine it, your patient can't afford abiraterone, enzalutamide, or doesn't want chemotherapy, maybe that's a situation where you can use this. Satyajit had said, yes. So Satyajit, so one important thing we need to understand is whenever you're going around radiating oligometastatic sites, PFS is bound to be better. So whenever you're talking about a trial where you're radiating or, there is some metastasis directed therapy, overall survival should be the primary endpoint. It cannot be PFS. So just imagine that you went around radiating 5 areas and in the other patient you didn't. Obviously, the patient in whom you gave 5 radiotherapy areas is going to progress a little later, unless you say that your radiotherapy was hopeless, right? So I wouldn't, say that PFS is a good endpoint in a study like that. It has to be overall survival. So that's important. Again, Dr. Nidhi, is there any role of concurrent chemo when abiraterone? No, there is no role for both of them together. It has to be either of them. Abhi, good evening, sir. Good evening, Abhi. How long to continue bicalutamide along with ADT and the role of bicalutamide with progression on ADT? Okay, again, the same answer. So bicalutamide, if for whatever reason you decided to use bicalutamide along with ADT, continue till progression. At progression, you would stop bicalutamide and do some other drug. If you're doing it in sequence, ADT, again, the same question arises. Why should you use bicalutamide? You should straight away get on and use either abiraterone, enzalutamide, apalutamide, or one of these drugs, rather than go and use bicalutamide in that particular setting. Again, the only situation where we would use is for some reason your patient cannot access these drugs or does not want chemotherapy. Pradeep, as usual, thanks for the appreciation. Given the benefit of newer agents in terms of OS in hormone sensitive and CRPC, in which setting would you prefer to use in a patient with prostate cancer? I think Dr. Ajit gave you the answer to that, Pradeep. I think it's important to sequence it, cleverly, should I say. It's not this or that, it is this and that. So I would say with the present data, the numbers are certainly favoring the new anti-androgen agents upfront. Look at this. All of us treat breast cancer, right? You can use chemotherapy upfront in a patient with metastatic hormone positive breast cancer. You can use hormonal therapy also. Where is that field going now? We are now saying that you should not be using chemotherapy unless otherwise you have visceral crisis and so on and so forth. So I think that's the same direction prostate cancer is taking now. You start with the hormonal plus the targeted agents, and then you go on to chemotherapy. It makes a lot of sense. Chemotherapy later might be able to tackle those clones which are starting to become undifferentiated. As you go by, the incidence of the splice variant, the androgen receptor splice variant, ARV7, keeps increasing. At the time of diagnosis, it's about 3%, 5%. As patients progress one therapy after the other, at some point in time, it's nearly 50%. So the likelihood that your newer anti-androgen agents will be very effective later, at least in theory, seems to be less. We don't have clear evidence towards that. So I would say start with the new anti-androgen agents and go to chemotherapy, but you can certainly do the converse. It's not wrong to do it, but I'm not seeing a great reason to do that with the present data. Sir, can you repeat why no benefit in the chartered? Okay, right. Nitish, very good question. So as we said, if you divide patients into 4 groups, patients who have had loco-regional therapy and relapsed with low volume, loco-regional therapy, and then relapsed with high volume, de novo low volume, de novo high volume. Now, in patients with chartered, in the chartered study, majority of patients with low volume disease were patients who relapsed after local therapy with low volume disease. Now, patients who relapse after local therapy with low volume disease have an inherently good prognosis. Their average survival with just ADT is around 7.5 years. So if you have a group of patients who inherently have good outcomes, then you're unlikely to prove incremental benefit by adding chemotherapy. Now, in the Stampede, which actually showed overall survival benefit in the low volume disease, most of these patients with low volume were actually patients who had de novo metastatic disease with low volume. So that is a group of patients which has a poorer prognosis, though not as poor as the high volume disease, but it also is poorer. So it's the patient selection in the trial that also ultimately determines what is the result that you get. So you should be very clever in the way you design studies. Of course, all of us are very wise in retrospect that way. I hope you understood that. Stalin, thank you for the compliment. How long should ADT be given? Which GnRH analog is given? ADT should be from the time of diagnosis to death. Simple. Which GnRH analog is to be given? There is nothing to say that one GnRH analog is better compared to the other. So it can be triptyline, it can be goserelin, it can be leuprolide, whatever is your choice depending upon logistic cost. Sharat, thank you for the compliment. Pradeep has got another question. In the hormone sensitive setting, there is no role of bisphosphonates, but if a patient has multiple spinal mets and symptomatic, can we consider using bisphosphonates? Good question, Pradeep. So in the Stampede study, they clearly looked at the role of bisphosphonates in patients with hormone-sensitive prostate cancer and multiple bone metastasis. Clearly, there was no benefit for the addition of zoledronic acid in terms of improvement in the ultimate outcomes, which is overall survival. They specifically did not look at bone-related events. But if you look at the earlier studies, there seems to be no benefit of the addition of bisphosphonates in that particular setting. So the simple answer to your question would be, I would not use it in the hormone sensitive setting as regular therapy for bone metastasis. I would use it on day 1, and that is to prevent osteoporosis because you're using ADT. So the simple answer is no. Dr. J. Mehta. Good evening, sir. How should we proceed in patients with metastatic? What is CNPC? Patient with, I don't know what is CNPC. Dr. J, can you type again? I'm not able to comprehend what CNPC is. Sharat, what is the concept of anti-androgen withdrawal? When to suspect, diagnose, and deal with it also is also seen with neuro anti-androgen. Okay, Sharat, so the concept, it's like this abscopal effect. Okay, so what is this abscopal effect? You ended up treating one side and all the other sides started going down. So similar is the case with this androgen withdrawal. We think that over time, this androgen can be a promoter of growth. The androgen deprivation therapy can actually end up promoting growth rather than inhibiting growth. So that happens in a very small group of patients and is just confined to some PSA responses, not really radiological responses. So I think as a concept, it looks good, but in today's practice, I don't see a role for anything like that at all. That is what it is. So the concept is very attractive, but there's no role for that in today's practice. Do abiraterone or enzalutamide work more in medical castration versus surgical castration? There's no evidence to say anything like that, Dr. Abhi. Dr. Ajit has given you the reference for the non-ADT, the typical ADTs that we are describing, finasteride plus bicalutamide. Thank you so much for that information, Dr. Ajit.
Yeah, Jay Mehta has given this is castration naive. So how should we proceed in case of metastatic castration naive hormone sensitive prostate cancer?
Oh, that's what the whole talk has been, Jay. So it should be ADT plus another agent. It can be a newer anti-androgen or docetaxel, one of those two. Thanks, Murli, for the compliment. Padmaj, you also are being thanked. Sachidit, will you prefer 250 milligram versus super question. 250 milligram in the fed state versus 1000 milligram in the fasting state. So if you want an unofficial answer, I will say 250 in the fed state. If you want an official answer, I will say 1000 milligram in the fasting state, because that continues to be the standard. But I think 250 in the fed state seems to be a reasonably good alternative, because they've looked at testosterone depletion levels, because that's what is the surrogate to outcome. It seems to be as good. So if cost is not a factor, I think we should stick to standard. But if the cost is a factor, 250 fed state is fine. Kinjal, thank you. Very crisp and clear. Brahmajit Singh, thank you so much. Sneha, thank you so much. Padmaj sir, you also are getting a huge thank you from Sneha for the teaching sessions. And congrats, Padmaj, again. Dr. Amrit is asking me, what is your monitoring strategy? PSA, clinical guided imaging, PSA and clinical guided imaging. So we would do the PSA once every 3 to 4 months. If there are any symptoms that warrant investigations, even if the PSA is low, because there are some patients in the long run who can end up having a neuroendocrine transformation. So just looking at PSA can sometimes be misleading. We don't continuously do imaging. Only if there is a clinical need or a PSA that's going up, doubling in a short period of time, we would do imaging, otherwise not. Sneha, most of the trials has PET for response assessment. No, it has CT for response assessment, Sneha. Now PSMA being more sensitive than PET. So PSMA is a type of PET imaging. So changing treatment based on progression on PSMA will help in changing overall survival. I think the answer is we don't know. So the question that you're asking is, if you pick up progression earlier and treat earlier, are we likely to improve the overall survival? The simple answer is we don't know. But I would doubt that you would end up improving the overall survival, because the intent is palliative. But I wouldn't find you totally wrong if you are thinking of a strategy like that. But we don't have evidence to say that so far. Kinjal, in your practice, do you observe early and deep response with NAA as compared to docetaxel? Any relevant of that in treatment planning? No, Kinjal. I think there is a prognostic value to the 4-month PSA as to how low it drops to, but I wouldn't look at changing my treatment based on how deep the response is in case of docetaxel or an NAA. When to suspect NET differentiation in CA prostate? What will happen to PSA levels? Will they decrease? Do we have to prove NET by biopsy, or we can do away with clinical scenario matching? Okay, so clinical scenario only is not enough, Abhi. That's the first answer to the question. If you have a patient in whom you're seeing worsening images, but your PSA is not going up, that's a situation where you suspect NET. If you're doing a PSMA PET CT scan and you're finding that the lesions, many of these lesions are not PSMA avid, that's a situation you suspect neuroendocrine transformation. You have a patient who is symptomatically worsening, but the PSA is not going up. That's another situation that you will suspect a neuroendocrine transformation. It is imperative to biopsy one of these sites in order to make sure that that's what you're looking at before you go ahead and treat your patient with chemotherapy. So that's the answer. Role of local RT to prostate in high volume disease, but if the patient has good KPS and local symptoms. So when you're doing it for local symptoms, it's palliative OM. So we would not call it with the intent of improving overall survival. That intent is to palliate a particular local symptom. No role for local RT with the intent of prolonging survival in patients with high volume disease. So no. Dr. Amol has said, thank you for an excellent coverage. Thank you. AV, correct, absolutely important. Again, very clinically relevant point that Dr. Ajit is making. Monitor testosterone level also, especially if you're on the GnRH agonist. You need to make sure that every 3 to 6 months with one of those PSAs, you're also doing testosterone levels. And when your patient is failing, even if you've not done it before, make sure that you're doing it in your patients who have worsening status. Asif is asking, sir, any role of neoadjuvant docetaxel? No, not yet, Asif. That's not standard as of now. Pradeep, apart from baseline PSMA, at what time points would you like to ask for PSMA PET? As I said earlier, Pradeep, we will not do a PSMA unnecessarily. So it has to be a significant jump in the PSA or a worsening of clinical status. Disease progression, in what situation would you ask for an FDG PET? All the situations where you're suspecting neuroendocrine transformation, FDG PET. Disease progression radiologically with normal PSA, FDG PET and biopsy. Tilak, 80-year-old metastatic disease upfront post-orchiectomy on ADT. I'm assuming that ADT means newer anti-androgen agent because orchiectomy is ADT. After 1 year, PSA is slowly rising, solitary mediastinal node, but patient asymptomatic. Should we change therapy? Are we sure, Tilak, that the mediastinal node is the cause of the progression? So I would first think that we should clearly have a biopsy from that mediastinal lymph node before I really decide what to do. Assuming for a moment that that is the only site that is progressing, I would strongly think that you should probably do some radiotherapy to that area if possible and continue on the ADT that you already have, because you don't want to jump and change the therapy when it is only oligo progression. But if it's very, very slowly progressing, then yes, there may be a role. In clinical practice, M0 CRPC, what percentage of patients fall into this category? Based on MFS, will you use ENZA? Such is it. I think the first question is, in the PSMA PET era, this category called M0 CRPC is now becoming extinct. I don't know which center. One of the centers in the West actually looked at 200 patients who had a bone scan and a CT scan chest abdomen and compared it to what happens if you do a PSMA PET in the same setting. They found that 98% of these patients actually were found to have some lesion on the PSMA PET. So in the PSMA PET era, it looks to be that the M0 CRPC group is actually a vanishing group. So what would you use? Would you want to treat early? Yes, with overall survival benefit that you're seeing in this setting, that we would not call this as M0 CRPC anymore. It would be castration-resistant prostate cancer, and we would treat that situation. So the answer is yes, I would treat, but it's a very, very rare category now. The answer to your question, which you asked at the starting, is NAA and ADT only, or to add RT also along with. Yes, we would certainly add RT to this patient, Abhi. You are absolutely correct. That's what I said, because it's only 2 lesions, it's low volume, and hence we would end up adding radiotherapy in this particular setting. Wow. So I think we have come to the end of the questions, Padmaj. That was highly interactive. I'm glad we had this topic because there were so many doubts, and I'm glad you are a little clear compared to 1 hour ago, I suppose, or not. I don't know. Let's see what happens on Monday morning. Padmaj, back to you.
Yes. Yes, thank you very much. Let's see how it changes the practice on Monday, as we say. Thank you very much for everybody for joining in. It was nice time with you all. Good academic session, good questions, and thank you very much. Good night.